Hi, I'm Art Caplan. I'm at the Division of Medical Ethics at NYU Grossman School of Medicine. For a long time in medicine, people who were learning to do intimate exams, pelvic exams, prostate exams, rectal exams, learned to do so on patients who were undergoing procedures that required they be put under anesthesia. I think a lot of people felt you're getting procedures done, let's say, in a teaching hospital, then you forfeit your right to say yes or no. These exams are not going to harm you. And it's important that students learn how to perform them and do them properly for the health of future patients. That's what teaching hospitals do. So a lot of places, both in the US, Canada, and elsewhere, had a long history of doing this kind of examination without the consent, almost always of women, but occasionally of men, to perform teaching of this kind of what I'll call intimate examination. Frequently, the patient never knew that that kind of teaching had been done, the intervention had been done, they weren't even aware. Well, I have to say, I've long felt that using a patient in this way without their permission, without their consent, even in a teaching hospital setting, is flat out wrong. Sometimes we get gray zones in ethics where you can make a case one side or the other. I don't see it here. I think you need permission from the patient before they undergo anesthesia, or even when they're conscious, if they're willing to serve as someone you train upon, to do this kind of an exam. It obviously has significant sensitivity in our culture. There are people who've been charged with sexual abuse for doing the same thing on a non-consenting woman. That's viewed as criminal. I don't think that's the risk here, but I do think we lose trust, we lose our patients' confidence if we're found out to be doing this kind of examination with no permission. Pennsylvania became the 20th state recently to pass a law demanding both written and oral consent prior to any type of examination, whether it involves anesthesia or not, for training purposes. Connecticut, where I live, had passed a law last year that I was active in trying to push through the legislature here, and we got it. So I think asking patients, is it all right if we examine you and use that to teach students, either when you're conscious or when you undergo anesthesia for some other procedure, is the way to go. And I think even in states that don't have those laws, that should be what we're doing. I also believe that the number of people who say yes is surprisingly high. I've had the opportunity to track a little bit of the impact in Connecticut, and there doesn't appear to be much change in the willingness of people to make themselves available for this kind of teaching. Most patients actually want to help. They do want to help the next generation of doctors learn. They know that they might be undergoing an examination that maybe could reveal something that wasn't suspected. There could be a small, tiny benefit in these exams for them. And even if you don't get permission, if you will, in the numbers expected, it turns out there are professional patients who, for pay, will be happy to undergo examination, and the pay isn't huge, as part of their work and as part of what they understand is important work to teach the next generation of doctors. So in sum, I don't think the practice of surreptitious, intimate examination or any form of examination should go on. I think we're at a point with informed consent where patients have the right to expect that they're going to be asked and give permission when something is undertaken that isn't part of their standard treatment. I also think we ought to give patients the right to participate. And as I said, at least in my state, the overwhelming majority of patients do want to participate and do want to help, and respecting that noble choice is something that bonds us with our patients, makes for a common cause in the battle against illness and disease, rather than being seen as people who might be doing things that are not trustworthy, that are sneaky, that are somehow shameful and not even brought up with the patient. That's not the position that medicine wants to be in. That's not the position that we want to really keep securing trust from our patients. I'm Art Caplan at the Division of Medical Ethics at NYU Grossman. Thanks for watching.